ask if members have any interests to declare.
None.
Right, thank you. Can we confirm the minutes of the meeting of the committee held on the 15th of March 2017 to be signed by me as correct record? Yep. Can we note the completed and outstanding actions arising from our previous meetings?
Noted.
Thank you. Guests, thank you very much for your patience, which brings us to our discussion this morning. Can I please welcome our panel of experts? First, Sinead Derwin, who's the Senior Mental Health Commissioning Manager in the Health and Justice System, NHS England. Glyn Thomas, Head of Implementation, Health and Justice, NHS England. Helen Dyson, Operations Manager for Health and Justice Department. I'm not sure what NACRA stands for.
It used to stand for the National Association for the Care and Rehabilitation of Offenders. Now it's just a word in itself.
Okay, thank you very much. And also Casey Newman, Head of Contract and Partnerships, London Community Rehabilitation Company, and Andy Bell, Deputy Chief Executive of the Centre for Mental Health. So welcome to all of you. Thank you very much for coming along. I'll start opening the questions, which I might direct us at individuals, but please feel free to contribute if you feel that you want to add something. Even if the question isn't directed at you, you can contribute, and we'll want to take as much evidence as we can this morning. So first of all, I just want to start with getting an overview of the situation, and I'll probably start with asking with you from Sinead, but we'll go around asking everyone. So the question is, how is the offender population particularly affected by mental health issues? Who are the communities within this group who are more likely to experience mental health problems? So if you just pick off there. Yeah.
Okay, thank you.
Thank you, Sinead.
Well, we've known for some time now, particularly from the last ONS survey that was undertaken in 1997, that there's high prevalence rates of mental health problems amongst the offender population, particularly within the prison population. And we know that there's a wide range of mental health problems that offenders experience, ranging from severe mental illness such as schizophrenia and bipolar disorder to what's sometimes classed as more common mental health problems such as depression and anxiety. We know there's high prevalence rates of personality disorder as well within the prison system. And although that there hasn't been a prevalence survey undertaken since 1997, it's felt that actually the need remains. There hasn't been a huge change in the needs. However, there has been other changes within the system. The prison population has grown. There's been changes around sentencing. We've got an ageing prison population, which we didn't previously have. We have much higher rates of foreign nationals in our London prisons than previously. And we know that BME groups continue to be overrepresented within the justice system and also within mental health services per se. So we know that they are particularly vulnerable groups, BME groups, women and older prisoners. We know that there are still issues around people experiencing autism, learning disability, also now referred to as intellectual disability, coming into contact with the justice system and often overrepresented there. So although that there is a move not to undertake, it's not felt that undertaking another prevalence survey would probably tell us any new information. NICE recently have also issued guidelines around the mental health needs of offenders, and they made some certain research recommendations. And one of those being that we do need to understand more around the mental and social functioning of this group, because that's probably what's changed, as I outlined, with the sort of changing landscape. And there's also been broader changes in society around changes in mental health care and changes around social care practice. And I think there's an understanding that we need to focus now on interventions that help, rather than counting the beans, so to speak. We know what the needs are, but now it's about understanding what are the interventions that can help this group and tackle the overrepresentation of certain BME groups and women and older people within the justice system.
Great, thank you. Did anyone else want to come in at the stage? Yes.
I think Sinead's excellent sort of summary of the situation. I'd just like to add that so people with mental health problems, they often have complex and multiple needs, so just an intervention to solve a mental health issue normally isn't sufficient. We have to have a wider, more holistic approach. There's not can quite often be comorbidities, substance misuse issues, and other wider sort of social aspects such as housing need, benefit advice, other sort of support services in a sort of wraparound approach to support people with mental health issues, not just focusing merely on the treatment aspect alone.
Yes,
just really to echo that, but I think also to understand that this comes from very often a lifetime of vulnerability. So people in the criminal justice system, the issues that have been described, in a sense they build from what we know that for many people who end up in the criminal justice system, many have parents who've been in the criminal justice system themselves or who have mental health needs themselves, most of which are unmet. Many have had behavioural problems from a very young age, which is the way children very often show distress. And we know that for many there has been a kind of path of escalating difficulties that have led into involvement in the criminal justice system. So there is a kind of there is a long kind of backstory, if you like, to their involvement in offending, and I think that's quite important to understand that for some people, being in prison, for example, is a trigger for poor mental health, and particularly those that have suffered traumas. Being in prison can revive difficulties that maybe have been dormant for some time in their lives. And in a sense, being involved in the criminal justice system, whether it's police custody, prison, probation, can both exacerbate problems that are already there, but also provide an opportunity to intervene. And I think that's where we've really got to kind of look at continuing on building on the progress we're making in that area.
I mean, all prison populations have difficulties, or any group of offenders. Because people have mental health problems, will have a different dimension of problems. So what are the specific health needs of the mentally health who are in the prison service? And are there any operational problems that are facing the service in providing those needs?
I think for me, part of it is volumes. There's a huge need in custody, and obviously each prison has only got a limited in-reach team who engage with people who've got mental health concerns. So I think, and it's the same in community, it's looking at thresholds. Because there's a limited capacity to deliver the service, the threshold doesn't actually capture everyone that I think requires that service. So I think there's in custody, I think the threshold tends to capture people who need the support. The difficulty, certainly for us where we work with mental health resettlement, is that actually in the community that threshold is different because the community mental health team doesn't have the capacity to deliver the same level of support. So the continuity of care is just not there. If people are not linked in with the community mental health team prior to release, then it's a telephone assessment which often doesn't capture the needs of the individual because it's over the telephone, you can't see how they present. And the community mental health team threshold tends to be much higher than custody, so that they tend to get the interventions that they require in custody, but perhaps that doesn't continue through the gate, and that's when you get the spiral and people end up coming back. So for me, that's a big.
So the health service in the prison, is it provided by the in-house health service, or is it commissioned from the main NHS?
So just to set the context for you,
Yes.
the NHS England Health and Justice teams are responsible for the commissioning of healthcare in a number of secure and detained settings, and that includes all the prisons, immigration removal centres, sexual assault referral centres, and some initial accommodation in London for asylum seekers, and police custody suites, and magistrates and crown courts. So in regard to prisons, we are responsible for commissioning a wide range of healthcare, so that's full primary care services, so GPs, nursing, dentistry, podiatry, etc., and mental health care. And there is a mental health, as Helen was referring to, is called InReach, so there is a team who works with people on the wings, and then we have an inpatient facility as well in the prisons around mental health, for mental health and physical health. So we're responsible for the commissioning and contracting of those services. And in our London prisons, we have a range of providers delivering those services, from mental health trusts, some private providers also, and working in partnership within the London prisons. Within our contracts, we do specify a continuity of care function. So for people to receive continuity of care, whether it's around a physical health problem or a mental health problem around long-term conditions on the release of prisons. And we try where possible to work in partnership with the CRCs. I think there are some challenges around what happens around continuity of care within the community and eligibility for services. And that includes not just mental health care, that includes housing. Is obviously always a key feature, employment, resettlement, access to meaningful occupation and activity. So it's a wide range of issues that we have challenges around in terms of continuity of care and resettlement.
I mean, we can explore a bit more detail later on about the liaison between these, between the community care and leaving the prison service. So we will park that for a moment. Have the challenges that have, I mean, we've had pressures on the NHS, right, and social services in the main community, but have the prison service had the increase of pressures, of financial pressures put upon them?
I can speak for London in
Yes.
terms of how we deliver care for commissioned healthcare services within London.
Yes.
And I feel that we're in a good position
Okay.
around the commissioning of our healthcare services within the London prisons.
So in London, all the prison services are commissioned centrally by NHS London,
Yes,
rather than
England.
the CCGs.
Yes, so prior to the formation of NHS England, the responsibility for prison healthcare commissioning sat with PCTs, which were then PCTs. And one of the many benefits that's come around actually from NHS England holding this direct commissioning function is that we now have a pan-London approach to commissioning of all our prisons. So we have a lot more consistency around the delivery and commissioning of the care. And we have one team, who do it for London rather than do it sitting individually in PCT. So as well as being able to share an awful amount of resource, expertise and experience, we've also been able to obviously make efficiencies within that around having a joint approach.
Okay. Before I hand over, I mean, from my point of view, I mean, it could be thought that if a mentally ill patient ends up in prison, it's a failure of the NHS healthcare they've received out in the community.
What, sorry?
It's a failure of the care they've received in the community. Would I be right in thinking that or wrong?
I think it's more complex than that. I think it's very difficult to pinpoint a particular reason as to why somebody with a mental health problem would end up in prison. There could be a whole range of reasons behind that if you track back what had happened to that person. And poor mental health isn't just associated with perhaps what you receive from your local mental health team. So it's also about, again, housing, it's also about employment, and it's about social relationships and networks and support. And if you haven't got all of those things, then you're at increased risk of your sort of poor mental health anyway. And if you're already susceptible to mental illness, that's going to exacerbate your problem. Where there are, for London, which you might want to come back to, we can talk more about it later, is around our liaison diversion services, where we have nurses working in police custody to really intervene early and pick up people who are mentally unwell and been coming into police stations to try and divert them out of the justice system where appropriate. However, at times, somebody may have committed a crime that actually they need to be going through the justice system, and the crime is so severe that it needs to happen whether they have a mental illness or not. There may be a link between their mental illness and their offending, there may not, it also depends. And again, if there is a link between their mental illness and offending, to understand what happened to that person at that time of that offence as to why they were offending, and understand had they dropped out of treatment, were services failing them, is quite a complex scenario to understand and unpick, and I wouldn't want to make a sort of general statement around failure of services in those situations.
Thank you. Yes, Andy.
One of the things we know from talking with people who are in the prison system or the criminal justice system is very often you do have histories of intermittent contact both with children's mental health services and adult services, and I think there's something there about certainly the thresholds that those services have, but also many are found to have kind of multiple and complex needs, as other colleagues have said. It's not mental illness in a bubble on its own, but very often they have lots of problems, none of which are regarded as kind of serious enough in a diagnostic way to allow them to receive a service. So you have people whose total needs are very, very high, but we had services still based in individual silos, as it were, to overuse a word that's often used. And so they never quite reached the threshold to get support. And others, we find increasingly, those who are vulnerable to offending, very often find the way services are organised, the language they use very off-putting. So young people, particularly from the more deprived parts of London, very often report if they've had any contact with mental health services, they don't trust them. They think they're very much based on a kind of diagnostic model. They're trying to find out what's wrong with them. And so they drift out of contact very quickly. So I think there's something about the way in which our mainstream services, particularly for children and young people, are engaging with those who are at risk of offending either now or later. If I can just pick up the thing about what's happening in prisons. We've recently finished an inquiry with the Howard League on looking at what could reduce the risk of people losing their lives through suicide. And I think one of the things that came out of that very clearly is a sense that while the NHS commissioned services in prison are incredibly important and they need to offer a kind of stepped care model, so different needs at different levels, much of the kind of day-to-day care is provided by prison officers. And I think there is an issue of the national shortage of prison officers and the reductions in numbers that has increased vulnerability. It means prisoners are spending more time in their cells, for example. They're getting less one-to-one care. And we've picked up a sense in which very often if someone discloses vulnerability, which is a quite brave thing to do if you're a prisoner, sometimes people aren't believed. They're seen as trying to get privileges and special treatment. And I think there is something about how we create a system where if someone does disclose distress, that is actually believed, it's dealt with, and rather than trying to expect health services to solve all of the problems, we actually need to look at the way prisons work as a whole so that they do become more responsive to people's psychological needs.
Can I just on that, you've said there's a shortage of police officers, obviously. Is there a training issue here as well? Is there the competence of police officers, prison officers to recognise those symptoms of mental distress?
I think that's certainly what we've found, and I think prison officers have said they want more training and support on mental health. They feel that they don't have the knowledge that they'd like to have. But also I think we've identified a real need to support the well-being of prison officers. It's an incredibly difficult job. They are witnessing and part of very traumatic events. So actually being a prison officer in itself can be quite a traumatising experience. So I think there's both how we develop the skills and knowledge of prison officers, that we have sufficient so that we know that they're able to provide that kind of support to vulnerable prisoners, and that where they have experienced a trauma, they're actually given the proper support themselves, because it is a quite vulnerable workforce.
Yeah, I mean, it's very difficult if the workforce themselves feel stressed by the health system to give care to people who have mental health illness themselves. You talked about threshold, right, of getting care, right? In the people have difficulty getting, they don't meet the threshold for the care, right? Okay. Has there been a change in the thresholds, or has the threshold been the same, or has the threshold been lifted high over the last few years?
Anecdotally, I think there's certainly a sense that the thresholds have risen. Mm-hmm. And in some way that's a way of managing demand. We know that across the country, yes, mental health services between 2010 and 2015, with the best information we've got, which is based on freedom of information requests rather than official data, had an 8% cut in funding. Mm-hmm. And of course that's very difficult to manage when they're already running a pretty kind of high level of activity. And so there is certainly a sense that some community teams, for example, have had to raise their thresholds, and that both applies to both children and adult services, in order to cope with demand, because inevitably they have to deal with the people who have the most present needs. And in a sense, all the evidence tells us that you need to focus on early intervention, you need to focusing on getting people help as quickly as possible. And I think people know that, but they also know that they're dealing with very scarce resources, and mental health hasn't had the same protection as other parts of the health service has. But I think, in a sense, service thresholds are decided locally. So you can't say, yes, it's definitely gone up across the whole of London or nationally. I think what you observe is individual changes in decision-making at the very local level.
Okay. Thank you. Andrew?
Could you tell me, perhaps the NHS could let me know, that, what do liaison and diversion services aim to do?
But they aim to identify vulnerability at the earliest point that an individual comes into contact with the criminal justice system. The earlier we know about their presentation, then the more we can do to intervene and provide immediate responses, and to provide information to key decision makers within criminal justice agencies so they can make more informed decisions about how they process that particular case through the criminal justice system. And so it's about capturing that person and identifying their vulnerability really as soon as they come into contact with the police. That could be in the case of a voluntary attendance on the street, or it could be, or more likely in London, to be when they arrive within a police custody suite. So
you do aim to have some kind of intervention pre-sentencing?
Absolutely. In order to get the best effect from liaison diversion, you have to identify the person at the earliest possible point. And ideally that would be before that person is interviewed and processed by the police. So capturing them on their reception into police custody so they can have an initial assessment that can inform whether they need to have the services of an appropriate adult to advocate on their behalf and to safeguard their interests, to ensure they get any immediate health response, but also to really assist a custody sergeant working within a police custody suite to make decisions about their safe detention and to assist in determining whether it's appropriate to interview or charge somebody.
And presumably, which agencies do you liaise with in order to provide that package of services?
Well, so liaison diversion services are directly commissioned by NHS England. If a person was identified with vulnerability, the provider of that liaison diversion service would have access to NHS data on that individual, and we'll be able to interrogate that data to get some history. And they liaise with a wide range of both mainstream health and social care services and third sector services. One of the strengths of liaison diversion is they reach out into the locality. They're aware of the services that are out there on the horizon to meet this cohort of people with complex and multiple need.
So what would a perfect or high standard liaison and diversion service for offenders look like? And how close are we to achieving that aim?
Well, NHS England has introduced a national service specification setting out the standards and outputs that are required from liaison diversion. That was introduced 3 years ago, and that's now operating across the whole of the north of London and good established service in the south. Sinead can tell you more about the detail particular to London. So
you're saying in North London
it meets the national service specification. Sorry?
But South London it's yet to meet the spec.
There is good legacy cover that we've inherited, but the additional investment for the liaison diversion programme is phased. We get increased funding from the Treasury each year, and we have a national rollout programme to roll out this service specification. So it's timed, but the uplift for the south of London is due to come in during this financial year.
So just to clarify on those points, so it's across North, East and West London where we have the enhanced operating model that Glyn is referring to, the national service specification. So we are covering 20 boroughs in that area with the enhanced operating model, which is working across 22 police stations and 8 magistrates' courts and 4 Crown courts across North, East and West London. And the model is teams of nurses, predominantly nurses, but some social workers and support workers working with the people who are identified in the system across that area. In South London, we have also all the police stations, metropolitan police stations covered in South London, and a number of magistrates' courts and Crown courts. There's just a slight difference in terms of the operating model. So They haven't received the extra investment as yet to enhance the service through community support workers and extend their operating hours.
So, so you almost answered my next. Well, perhaps we can get the view of other people how those liaison and diversion services working, perhaps from the Centre for Mental Health.
So, thank you. I mean, we've had a look a couple of years ago at some exemplary liaison and diversion services, and we were also involved in setting up specific services for children and young people, for people in the criminal justice system under the age of 18, which is now included in the all-age model that NHS England is developing. And I think some of the elements that came out in terms of what really good looks like. First of all, they are able to work with children and young people as well as adults because their needs are different and the services they interact with are different. So very often for a young person who's involved in very petty offending, it may be that the most crucial thing you do is get them back to school and stop them being excluded. It might be that you get them family therapy to help them and their parents rebuild a relationship that's gone a bit wrong. So sometimes the interventions can be very simple and straightforward and very social. Not so much clinical, not so much getting people into treatment, but sorting out whatever are the issues in front of you. We've also found that very often liaison and diversion services, in a sense, they're the pivot point for how you support offenders by identifying need at that crisis point when they're getting into touch with the police or in the court. It's about engaging with people on whatever they need. And very often that's about having something to eat, somewhere to sleep tonight, and some money coming in. So again, very, very basic stuff, because these are folks who are in a crisis. And then very often it's about knowing all that range of supports that are available, being able to work with people from a range of minority ethnic communities, particularly in London, where you've got a very diverse range of people who, again, we can't assume everyone has the same needs as everybody else. But also, crucially, we've noticed that what liaison and diversion do is, first of all, they inform decisions. So, for example, by the Crown Prosecution Service, by the police, about whether to charge someone, by the courts, about whether you imprison them or perhaps give them a mental health treatment requirement on a community order. So, reducing the use of custody, which we know is disastrous for people's mental health. But also, they have this function which is less well known but really important, of building up the confidence and knowledge of police officers, court staff, on dealing with mental health issues so that it becomes normal and regular, because it is. When Lord Adebowale did his inquiry into the police and mental health, he observed a lot of people saying, well, mental health isn't our business. Well, actually, it is the business of the police. It's core business for all criminal justice services. And what liaison and diversion workers do is they build up their knowledge and confidence. And I think that's an incredibly important function that over time will hopefully have very, very many benefits. So it is a quite multifunctional role, but I think it's absolutely essential, and without it, all the other things that we want to happen in the system really won't.
So it's a work in progress, we're moving towards it.
It's work in progress, it's fantastic work in progress. Colleagues have described kind of the current state of play in London, and clearly there is more to do, and we have to make sure we maintain the standards. And it's, of course, absolutely fundamental that where you've got these teams, and I'm sure we'll come on to this later, that they've got good community-based services to refer people to. Otherwise, you're missing a golden opportunity when someone is in contact and is getting that immediate support to make sure they latch on to services that are really going to help them.
Are there anybody else coming in on that? I mean, perhaps we could talk about how the liaison and diversion services have been affected by funding changes over the last 5 years. Has that had any effect on their performance?
This is programme funding from central government. So the NHS has been in receipt of funds from the Treasury rolling out this, because it's a cross-agency programme, it's a cross-government programme. So it's in governance terms, it's led by the Department of Health with the Ministry of Justice, the Home Office and NHS England as core partners. So it's received a funding stream. We were required to complete a full business case demonstrating the benefits and values of rolling out liaison diversion services, and that was approved last year with some conditionality to go back to show how we've delivered longer term health and criminal justice outcomes, and we're in the process of evaluating those longer term outcomes at the moment. So it's not been subject to budgetary cuts. The funding has been guaranteed and in effect ring-fenced during the period of rollout of the programme.
Lucky you.
Well, no, I
services which can say that.
I think that's some of the confidence from the cross-government programme is that, you know, people can see we can be able to demonstrate the value that this service delivers both to the health and criminal justice sector.
And perhaps NACRO, perhaps you can tell us how you see these liaison and development diversion
So for me,
services.
I think it's all about early intervention, whether it's with criminal justice, whether it's mental health. And so I really welcome services like this, particularly because a lot of the services that I manage are in custody, and I see people, like colleagues have said, that have accessed services for a number of years or they've been in the criminal justice system for a number of years, several times, almost at the point where they're not sure if they can ever get back to where they would like to be. And so for me, I think early intervention is key, whether it's offender mental health or anyone's mental health. So I know NACRO have been doing a lot of policy work around liaison and diversion. So we're definitely a big champion for it. And for me, I think if we can shape services at the front end so that I get less service users coming through to me in custody at the back end, then that can only ever be a good thing.
So we're in a situation where we're aware of that southern tranche of boroughs currently undergoing development to enhance status. Are there any other areas where perhaps the liaison and diversion services are not delivering for any reason?
I don't think that the services aren't delivering. I think we're actually heading in a very positive direction. I mean, I'm always cautious when we say the South is under development because we still have good provision in the South.
Yes.
They just don't have it as the enhanced operating model.
It's all semantics.
Sure. But there are some other areas that, this is specifically for London, which is quite different from the rest of the country, around where we've slightly extended the scope of liaison diversion services to work with our policing partners. So we have also a service working with Counter-Terrorism Command within the Metropolitan Police to support the police and the process around identifying people who may be at risk of radicalisation and who have mental health problems. So we have a team, we commission a team there, also working with CTC. We also work with British Transport Police. So the liaison diversion services cover British Transport Police custody suites as well as City of London, as well as Metropolitan Police. But within BTP, again, it's a slightly enhanced service, as we call it, because there's a huge focus on suicide, obviously with BTP on the networks. So we have a team that supports officers and works in partnership with British Transport Police to support people and the officers around suicides on the network and trying to get it. And it's like a triage liaison diversion model which works across the rail network as well.
And I understand there is the government's undergoing a review of liaison and diversion services at the moment. Do we know what that review is looking at, or is there any early?
It's not a review as such. It's the longitudinal study that I alluded to earlier, in order to demonstrate the longer term health and criminal justice outcomes from liaison and diversion. We've got an organisation called Round Europe that have been commissioned by the Department of Health to undertake this study, and we're currently at the stage of gathering a cohort of individuals passing through our services, and we will monitor them over time to assess whether they have reoffended and the amount of contact they've had with the criminal justice system, and also look at the way they've utilised other health agencies by matching data against a range of government databases. But that's a work in progress which is due to report in 2019.
Okay, that's not what we thought the review was. Which, I mean, the review sounds, from what you're saying, it's more like a proof of concept, putting the evidence together for justification of the service.
It's looking to demonstrate longer term health and criminal justice outcomes. But we've already had an initial process evaluation when this programme commenced to look at the way the new service was being implemented, mobilised and embedded. gathering a range of feedback from stakeholders at all stages through the criminal justice and health processes. And that gave evidence of sort of increased confidence, as we've already heard, about decision makers in criminal justice agencies. The judiciary and the police having more confidence by having that more rounded knowledge of an individual. So a lot of positive information came from that, but it was essentially just a process evaluation, reviewing how these services had initially embedded.
So it's not really an organisational review then. It's not.
No, I think we're still relatively early in the process. We're only really just completed the third year of a rollout programme with aiming to complete this rollout by 2021. So we're not at a stage where we want to do a fundamental review at this stage.
Okay. Any other questions on any other answers on that? Lovely. Thank you very much indeed.
Yeah, I just want to pick up the liaison service obviously depends on a good service in the community. I mean, if prisoners are being moved from inside the prison into the community and you want to liaise with the services, we need a good service in the community where there has been a lot of stress. Are you facing any challenges with this?
What, sorry?
Are you facing any challenges? Because I mean, you may have a wonderfully planned liaison service. You may have all the knacks on it, everything. It's all singing and dancing. But if there's no service in the community for them to pick up, right, you are on to loser. And what I'm saying is, are you facing those issues, or are you able to do a good transition?
It would be naive to say there aren't challenges, obviously, within that pathway.
Because that pathway isn't under your control, that's under the CCGs.
Yes, that's right. So NHS England, as you rightly point out, are responsible for commissioning the liaison diversion services working in police stations and courts. And then the CCGs commission the pathway that we're trying to refer people into. But there's also a range of third sector agencies that we refer to as well that services utilise.
So that's the voluntary sector or the third sector you're saying?
Sorry?
Is it the voluntary sector you're referring to?
Yes, yeah.
Okay. Who are also facing a lot of cuts?
Yes. So there are challenges. What the data tells us from looking at through liaison diversion services, we looked at the data for this year across the north, east and west boroughs, the 20 boroughs I talked about who received the enhanced operating model. And almost 50% of people coming through the services are already known to services within the community. So a lot of the role is often getting people re-engaged with those services. They may have dropped out or for various reasons that they may still be receiving care, and there's other things going on in their life while they're offending. So we know 50% of them are known to services, so a big part of it is actively re-engaging people. And yes, there will be, as referred to earlier, there have been some shifts in eligibility criteria and thresholds, but we also do see a high number of people with severe mental illness. So in terms of our data that we looked at for this year, that 50% of people known to services, 37% of those have a diagnosis of schizophrenia or other delusional disorder. So, that's a high percentage of people with severe mental illness who are eligible for services, actually. We often think they're not. So I think sometimes we talk about this, there is the sub-threshold cohort of people we talk about, which absolutely, who come to our attention and absolutely need to be engaged in services. But there are also still some very unwell people who are getting into services, but it's about, I think, enabling that reenactment into services and ensuring more practical support to help you make your appointments and keep your appointments, etc.
Do you want to say something, Andy?
Yeah, I mean, I think this is absolutely a fundamental question in a way. We're developing liaison and diversion. It's a huge success story. But I think that's in the context of, as colleagues have described, people who come into contact with the criminal justice system often have complex needs. That can include difficulties with drugs and alcohol, difficulties with housing and money. And I think we know that drug and alcohol services are under enormous pressure, particularly alcohol, actually, which has never been very strongly funded. We have very, very low rates of access to treatment for alcohol difficulties. And certainly in the early days of CCGs, I think because prison healthcare was moved to NHS England, there was a sense that we're not responsible for offenders anymore. And I think hopefully that's beginning to change, and colleagues at NHS England are doing a really important job of helping them to understand that actually this is core business for them. This is a group of people who are at the wrong end of a lot of really bad health inequalities. And I think the same conversation needs to be had with the boroughs. They're responsible for social care. Social care, as we know, is incredibly important for people with mental health difficulties, but under enormous pressure. Housing support services are experiencing probably bigger cuts than almost anything else, and again, that's fundamentally important. And in a way, this should be a priority for public health as well. So in a city like London, where you've got very high levels of quite complex need, we would expect any joint strategic needs assessment to include looking at the needs of offenders and people at risk of offending, and ensuring that there is action to prevent and support at every stage of a person's life. And I think at the moment it's probably something that we're in the early stages of building up.
Thank you. Yes, Casey, you want to say something?
I think from a CRC perspective, I think I would echo some of those challenges around how at a local level across the boroughs those thresholds will differ. So it's, for us, the difficulty can sometimes be navigating and understanding 32 different boroughs that may have 32 different thresholds depending on what the need of that individual is, and that can be quite difficult when you're a pan-London service. And also just to add around the transition out of custody can sometimes be made more complex for those that are serving short sentences, so they don't serve long enough in custody to perhaps have a full assessment and a diagnosis for that continuity to be then followed out into the community, so you're then sort of re-referring back in once that person's released. So I think from a perspective of probation services, one of the things we would really welcome is that sort of additional support and transparency around what those thresholds look like and how we work most effectively with our colleagues to ensure that people can access those services that they need.
Great, thank you. I'm sure there's something which my colleague will pick up, yes.
Thank you. I'll address my comments firstly to Glyn, and maybe everybody else can add comments on the way. Traditionally, how successful have prison services been at meeting the mental health needs of prisoners, people who've been incarcerated?
It isn't really my background in prisons, so I preface any comments I make. Probably Sinead is probably best placed to answer that.
Sinead?
Yeah, so just to set the context for you, prior to, I think it was 1999, the prison were responsible themselves, prison service, for providing healthcare for prisoners, and then the transfer, the commissioning came over to, which was then PCTs for the commissioning of healthcare for prisoners. And I think it's fair to say since that's happened, we have a much more standardised approach now to the commissioning of healthcare around physical healthcare and mental healthcare for prisoners. Our contracts and our services that we commission are informed by, we have health needs assessments to understand our population and understand the prevalence rates of what's happening within the prisons. And then services are commissioned and tailored to, service specifications are tailored following those health needs assessments to meet the needs of that population. And within that, we also, equivalence of care is crucial, so we are working towards, and have been since the point of transition over to the NHS of the commissioning, around ensuring that there's equality in the healthcare delivery for those who are in the prison population to those in the community. So if you're deprived of your liberty, you shouldn't be deprived of equal access to healthcare whilst you're in prison. And I think that's been quite a shift in the change. So I think historically perhaps the prison service or prison estate hasn't been hugely effective in meeting the healthcare needs of those in their establishments. But since the transition to NHS England and PCT, CCGs and NHS England, I think there's a much more standardised approach to healthcare that's informed by robust commissioning processes.
But that sounds to me that to be slightly crass, that works for the system. Does it work for the prisoners? Because the figures would suggest around suicide, self-harm, etc., that they're on the increase. So has this changed? Are we yet to see the effect of that positive for prisoners? Or is there a change ineffective because it doesn't seem to be reflected? All that effort doesn't seem to be reflected in outcomes for prisoners.
It would be interesting, which I don't have to hand, to look at data around what was happening to the prisoners' mental health needs NHS commissioning and post NHS commissioning. I think there are challenges in the enabling healthcare within a prison environment. There are challenges around the delivery of healthcare. I think, as we've outlined before, the needs remain within the prison population, which is about colleagues' comments earlier around early intervention, about what's happening in that person's trajectory in their life prior to coming into prison, which we've a long way to go in tackling that still, in terms of early intervention, people's start in life, people going through the care system, education, employment. That always has an impact again on our prison population and what's happening in the prison population. That still has huge challenges, that area. We know, yes, there are high rates of suicide amongst the prison population. And in terms of whether we don't have any evidence today to talk about whether or not the mental health needs are being met adequately through our commissioning that has a link to the prevention of suicide. That's not, research hasn't been undertaken in that area, and we don't have hard evidence around that. What I can say is that we know that there is a standardised approach to the commissioning and provision of mental health care within prisons. The complexity of the prisoners remain. The enabling of the healthcare, as at times is challenging within the prison environment, which overall will obviously have an impact on the outcomes for people within prison as well.
I'd like to echo that. I think I've got teams in a number of prisons, and I think we have really positive experiences of healthcare delivery, but there's always issues around whether that can actually be delivered. I think that the state of custody currently, with kind of understaffing and the dangers of custody, and the environment as a whole often means that you can't access prisoners can't access the care that they need. So I think it's a wider prison issue. I don't necessarily think the healthcare provision isn't there. I think it's how people are able to access it and how it's able to be delivered.
So you actually talk about the physicality of being in prison?
Yeah, I mean, we have prisons where weeks on end it's lockdowns and no one's coming out of cells, and if they can't come out of cells to receive interventions, then obviously risk of suicide is going to increase if people are locked up 23 hours a day. So I think we need to look at the prison regime as a whole rather than access to healthcare, I think, from my experience.
So there's a feeling, so you're, correct me if I'm wrong, you're saying that the healthcare package in prison, probably both physical and mental, needs to be seen as part of prison rather than a bolt on it. It can be hard to admit.
Yeah, I mean, it is integrated into the regime, but I think all elements of delivery in custody, if there's not enough staff, everything just stops.
Okay.
So resettlement services that we deliver, trying to get people accommodation, jobs on release, everything like that. If we can't see them, you can't do that work, and it's exactly the same for healthcare. So I think I don't necessarily think it's that the services are not there or are not adequate. I think sometimes it's that the prison regime doesn't allow people to access the services when they're required.
That sort of touches on my next question, because I want to look at the mental health care pathway through prison, and is there any areas of it you think need particularly addressing? Are there bits that could be done better? Are there examples of best practice that could be more widespread across London?
So for me, I think it's the through the gate bit. I think the delivery in custody, our experience of working alongside healthcare teams in custody has always been positive, and the services that prisoners receive, I think, are positive and are kind of on a par with what they would expect to receive in the community, if not better sometimes. In terms of waiting for appointments, you'll sometimes get complaints that they have to wait 2 days. Well, the reality is in London, if you're in the community, you have to sometimes wait 2 months. So I think for me it's about, like we said earlier, making sure that care continues when somebody's released. That's the key part, I think.
How will the government's reforms for prisoners improve care for that offenders receive? And how will the public see governors? How will governors be held accountable for that improvement in care or not? I suppose, in your fairness,
It's a shame there's not someone from the prison service.
There's a long...
I mean, from a London CRC perspective, we deliver through the gate services in custody. So on initial reception into it, we do an initial screening, and then 12 weeks prior to release, we will then work with them to prepare them for release. I think one of the challenges for us is integrating the information that comes from healthcare into that, because we're reliant on self-disclosure from the service user themselves, because of the information sharing agreements and issues around that. So that can be quite complex in terms of planning and sentence planning, when actually you potentially have got an individual who may not wish to continually disclose potential, quite high levels of vulnerability to multiple parties over what might be quite a short period of time. So if we aren't, as an organisation, privy to that particular need, then we could be planning for their release without knowing some of those complex health issues. So that's really, from a CRC perspective, the only thing I can contribute. I'm aware of some of the wider conversations around the prison.
Let me move on slightly and ask, to what extent is mental health care prioritised as part of the probation process?
Yes, absolutely it is. I think what we know is that the prevalence of mental health issues across our cohort of service users is high. I mean, the Department of Health data suggests it's around 90% of our service users will have either mental health issues and or substance misuse issues. So London CLC commissions St Andrews Healthcare, who provide 4 assistant psychologists and 2 senior assistant psychologists, as well as some psychotherapists, to deliver interventions within the community for those individuals that meet that threshold, in order to try and improve their compliance and motivation with perhaps some of the services that are already being provided for them. Because what we know is that some of these individuals are quite chaotic, they don't engage particularly well, so we look to enhance that service to try and improve the chances of them engaging with that, and therefore improve the outcomes. All of our frontline offender managers have been trained in a KESLA 6 assessment, which is a screening tool used to try and identify and flag up mental health concerns at the earliest opportunity of engagement. So then that will start a discussion with St Andrews Healthcare about what the best route of intervention might be for that particular service user. And as part of the risk assessment and sentence planning process, all of our offender managers will consider the mental health and physical health of a service user when thinking about how to improve their access to employment opportunities, improve their sort of social relationships, etc. So it's absolutely part of a full holistic assessment process for us.
How do probation officers feel about their level of training to identify ongoing mental health issues? Are they comfortable with that? Is there a definite training package? Is their training topped up across the years, or are they just set out into...
So, we aren't a specialist provider of mental health services, obviously, but what we recognise is the prevalence of that, and therefore, as I said earlier, London CRC have taken the decision to commission an additional service that then rolled out training across their frontline offender managers to equip them with the skills to administer this screening tool, to be able to recognise some of those signs and symptoms, and also provide them with the support through St Andrews Healthcare to talk about case discussions and improve their confidence, very similar to what you were talking about around the police service. How do we improve their confidence and ability to recognise the symptoms and know what to do with them? But I think that some of the challenges for us are, again, coming back to a pan-London service that has 32 London boroughs within it. The thresholds can be different from borough to borough, and therefore some of our offender managers will need to navigate that world and understand exactly what the needs are and what those restrictions may be within those boroughs. But certainly we're doing everything we can to try and improve their awareness and ensure that they pick those up at the earliest point.
And also stress the interface between liaison diversion services and the National Probation Service, who advise the court on sentencing. Really, an integral part of liaison diversion practice is that providing the offender consents, information about their vulnerabilities and their health presentation is shared with probation at the earliest possible stage. So that, even before they get to sort of sentence planning, probation staff are aware. And they're quite often co-located, the liaison diversion service and the probation service, really good working relationships. And it is that sort of confidence building we've heard 2 or 3 times mentioned, that grows. So we're not trying to make probation officers into mental health professionals, but we are increasing their confidence and enabling them to have those discussions with liaison and diversion nursing staff who are on hand, often working in the same space.
How you talk about co-location, you use the word quite often. How universal is the service across London? If I'm in one part of London, do I receive a better service than the other? How patchy is it?
The exchange of information ought to be the same level. Obviously, geographical, locality differences will vary. In some court buildings, they will share an office space. Half will be probation, half will be liaison diversion or whatever. The way that's configured will differ in different localities, but there's still a clear expectation that information about an offender's presentation will reach the appropriate member of staff within the probation service to enable them to start planning in as timely a way as possible.
I understand the expectation, but there's, to be kind, probation in London has had a number of challenges. It's been heavily criticised for lots of different things. So there's a massive difference between, or is there, let me ask it as a question, is there a massive difference between what we would like to happen or actually happens on the ground?
I can only talk in terms of the delivery from liaison diversion services, and I think we can be confident that where an offender consents for that information to be shared, it will reach the relevant person within the probation service. I can't talk for the knowledge base of probation staff. That's out with my knowledge.
Okay, Jeanette.
If you're finished.
I think Andy and
Sorry, do you want to come quickly?
No, just pick up a look, because I think there is something. We were very critical when the contracts were let out for community rehabilitation companies that there was no requirement to demonstrate what they were going to do to support the mental health of people on their caseloads. Clearly, London has gone out of its way to do extra and contracted with an independent provider. But I think that does show quite a significant fault line in the system, that it's left up to chance and good practice, that CRCs are providing mental health support, and that we don't know. And I think that does kind of create the need to perhaps understand across the country, not just in London, what kind of mental health support is being provided to people on probation caseloads. What does good practice look like, and how particularly do they engage with the local NHS? Because I think, again, from a basic kind of access to healthcare point of view, people on the probation caseload have very significant health needs, most of which have been poorly met up until their point they've come into contact with that. Again, it's a really important opportunity to offer good quality healthcare to that population, and I think perhaps we really need to look at what's going on and what kind of provision is there, and can we improve things across the piece.
Okay, thank you.
I think I would just add from I think the question around the interface between liaison and diversion services and probation services is really a matter for the National Probation Service, because the CRCs only get involved at the point that the sentence is completed or the sentence has been administered and started. So.
I think we've covered the point about lack of community provision. Okay, thank you.
Jeanette, you wanted to come in?
Chair, I just wanted to raise some questions about, if I can use the term, what would it be, black offender mental health issues in London, because we haven't touched on that. And we know from the evidence, indeed, from a black and minority ethnic community's mental health and criminal justice report from the Centre for Mental Health. So, Andy, maybe I could put my questions to you firstly. And I think it's something that has to be acknowledged, that we understand that for black and minority ethnic communities, there's a possibility that 40%, they're 40% more likely than white Britons to access mental health services via the criminal justice system, which is a really tragic indictment, isn't it? So basically you have to commit a crime, go to jail, and then the mental health issues that were there before are identified. In your report, what was one of the key failings? What were the key drivers behind that phenomena?
That's, I mean, particularly for African and Caribbean communities, I think that's something that's still incredibly controversial, and certainly from the work that we've done. I mean, it's now 15 years since the Centre published a seminal report called Breaking the Circles of Fear, which looked at the relationship between African and Caribbean communities and mental health services. That wasn't particularly in relation to criminal justice. But I think what that showed is a real fear in black communities that if you got involved in mental health services, you would end up in hospital under the Mental Health Act, potentially be at risk of losing your life. And I think there is a real fear on the part of mental health workers on how to provide good quality care to people, and so there was a real kind of literal circle of fear, as it were, between them. And I think that's played out in terms of the overrepresentation of black people, both in secondary mental health care, and the more coercive you get, the more the overrepresentation becomes, and the overrepresentation in the criminal justice system. There's a similar underrepresentation in things like primary care mental health. So psychological therapy services are less likely to be supporting people from black communities, and there's lower levels of diagnosis of common mental health problems. So there's a real systemic issue here, and one of the things that we've been looking at is how we can intervene earlier and look at what's happening to young people in schools and families to say, can we offer a more authentic and helpful kind of mental health support to young black people before they end up in this very negative circle of getting into contact with mental health services through the police. And I think that will have to be including a very strong kind of element of peer support, so working within communities to support communities. There are some very innovative services now working in different parts of London and indeed other cities that use things like peer referral. So rather than having a kind of formal diagnostic thing where you go to your doctor, you get diagnosed with a problem and then you get offered treatment, actually having a service which is much more open access, and people bring their friends along, and you receive mental health support alongside other things in a building that doesn't say mental health on it, which puts people off. So I think we really do need to look at this in a systematic way. And of course we need to ensure that liaison and diversion services have both the competence to deal with people from every background, but also contact with those community supports that people find helpful, so they're able to plug people into that support that's relevant to them, so that where someone is coming into contact, they're actually getting the right help at the right time.
I mean, given this this historic evidence-based fear, because many of us, Umesh and I certainly, remember those reports which were evidence-based. They weren't made up or anything. There was clearly a propensity to see transfers to higher security facilities, a lack of an understanding. It was if you were black, you were mad, and that sort of went along with the piece. And then, of course, you committed criminal crimes, and a dangerous time then and now to be a young black man on the streets of any city in this country, especially London. But now that we're where we are and we have these joint strategic needs assessment, I find it interesting that nobody has mentioned the ethnic dynamics in all that I've heard so far this morning, and we haven't talked about the variances in elderly the elderly prison population or the female population, which I'll go on to female reoffending later. But who can answer the question? Is it you, Sinead, about in terms of the needs of the service to be aware of the particular issues that arise when you have a black mental health user within the prison population, if I can put it that way?
I think, as we said earlier, that we know that there's over-representation of BME groups within the prison population, and often within mental health services who are detained under the Mental Health Act.
But what is the action? It's
so
a commission.
I'm just saying that obviously that we know that's fact, that's happened. Again, with the ageing population and women. So for liaison and diversion services, it's in the specification that we ask providers to deliver services that are going to meet the needs of specific groups. So, for example, we have dedicated women's practitioners to work solely with women, and we have got workers that they're under development around working with community services to enhance the referral pathways for BME groups. Because I think what's probably missing in perhaps standard NHS providers is that they don't have the speciality as such of working with BME groups, and that expertise is often held within the third sector and within the voluntary sector organisations, and that's where we want our services to work in partnership, because I think that there's not one answer for this within one service provider. I think it's about having a collaboration of providers. And for this year, just to help you set some context, so for 17-18, we are looking at all our provision of liaison diversion services across London. We're going to undertake what's called a remodelling exercise. So we're just going to kind of revisit what we've got, what the provision is, how equitable is it across the services, look at the data, analyse the data in more depth around what areas, for example, have got higher rates of BME groups coming through the services. We want to look at, and how many of those people then took up the services, or were they getting a lot of decline from the services, and then help us understand what the services are doing and how we can change and reconfigure the services to better meet the needs of that population. And that might be that we ask our current providers to partner with a third sector or another agency who can help meet the needs of it, whether it's women, BME, older people, or people with learning disabilities. It's another area where there's high representation of people with learning disability in prison, but what we're doing at that early identification stage, so those vulnerable groups, how are we meeting the needs of those? And we want that will, for liaison diversion services, that will be worked through in our remodelling exercise for this year.
It's just the last question, Chair. Can I just ask you, and no offence is meant, that answer,
yeah,
would I have heard a similar answer 5 years ago, 10 years ago? Because I don't understand what's new and why it's, from what you're saying, this is like groundbreaking stuff. We've had black users, black members of the prison service with mental health now for at least my lifetime.
Yeah, sure.
And I've been campaigning around this issue for about 50 years. So, and the way you said it, it's like, oh, it's all new to us. Is it because of the commissioning processes now that are being used that didn't capture the evidence prior? Will you be telling the same story in 3 years' time, do you think?
I hope not. I can't say whether, obviously, we would have been having this conversation 5 years ago. I can say, obviously, I know that, as you say, and as I know, my background is a social worker in mental health and adult mental health services, and I've seen firsthand the detention rates of young black men. I've sectioned young black men myself, and I understand the trauma of that experience for anybody, but I also understand how pertinent that is within a black family, and particularly for a young black man to experience that. And I think the way BME groups come into contact, particularly African and Caribbean black men come into contact with mental health services in the justice system, is complex, and it does go back to early starts in life, and it does go back to your experiences and how you're perceived, how the world views you, and how you end up interacting with the world. and how you can access help or not. And I think we're much later down the line, and we're trying to put a bit of a plaster on a fix. It's a generational thing that's happened. But what I can say is that as Health and Justice Commissioners, we are committed to trying to make inroads in this area. And like you say, it's old news in a way. And why are we still having this conversation? We also commission healthcare for Feltham Young Offenders Institution, and it really concerns me the amount of young black men that are in Feltham. Why are we still having this conversation? Why is that happening? I think the reasons are very complex. They're not in one straight answer. But what I can say is that we are committed to trying to develop our services to be more nuanced to the needs of many people and to be able to respond to them in the most appropriate way we can. There is a bit of the sticking plaster on a kind of a legacy and a generational problems that are coming through today.
Thank you for that answer.
Sorry, just to continue that line of questions before I go on. I didn't hear you say much about learning from the experiences of those groups. Obviously, as a young black man, and obviously, I used to be a youth worker, and I dealt with a large group of young black and Moroccan boys as well. But nobody seems to be taking the learning. None of what's been said today is new. This is historic. It's all very well reviewing your services. Of course, you should do that. But is there any way of capturing some of the problems that went on before so we can not repeat the mistakes? The most distressing thing about my colleagues' comments were, we've had this conversation before. It doesn't feel like, I feel I can say from the point of view of the black community, it doesn't feel like there's been any advancement in how we're dealt with. And if we are one of your biggest user bases, surely there should be a lot of focus on learning the lessons to develop something new.
I suppose just to set it in context that where my responsibility sits is within the commissioning, within a team of people who commission healthcare services for people in the justice system. And that includes a range of healthcare services, including mental health services. I'm not responsible for the commissioning of all healthcare and mental health care services across London, so obviously can talk about what we can do as a team for
I
ourselves.
accept that, and I don't want to labour the point because I think Jeanette covered it, but just to make a point, the people with the most power are the commissioners. That's a fact. In any conversation, the people with the resource have almost all the power, but that's just their personal belief. I just want to swing back to CRC. Speaking to you, it felt like quite a rosy version of what's going on in probation, but reading our notes, it's anything but rosy. And things like resettlement plans, etc., the training of your staff, their confidence, how effective they are in probation, and certainly looking at what HMI report had said about you, how confident are you that you are making the changes to deliver a really effective probation service, particularly around things about resettlement? Because if we're talking about mental health is every day, so how you resettle me is key to if I come back to the criminal justice system.
Yeah, absolutely. And I think there are 2 points on that. Is we've focused a lot on the transition of people from custody into the community, but there is also a cohort of individuals that go through the criminal justice system and don't go to custody. They go straight into the community film teams that are picked up by our probation officers, and we need to think about that interface as well when they haven't come through that particular route. To take your earlier point around the HMYP inspection, London CRC recognises obviously the comments that were made in that. A lot of what came out of that report was stuff that was already known to us, and we'd already embarked on our Ambition 2020 plan in July last year before the publication of that report. So whilst obviously disappointing, it highlighted things that we were already aware of within the organisation, and it started to make steps in terms of the transition and transformation of the service to capture some of those learning points, as well as many others. There's over sort of 200 work packages of work that the service needs to work on, and hence the time frame of an ambition of 2020 is a realistic time frame for achieving some of those huge changes, which include the upskilling of our staff, and that will include the quality of the sentence planning that they deliver, and will improve the quality of the assessments that they make. So we are absolutely on a journey to doing that and making progress as we go along, and that's something that we're continually in discussion with HMPPS about. but we recognise that, you know, that there are huge challenges that we need to overcome, and that will take time to achieve fully.
Okay, thank you.
Sorry, just to add, we deliver resettlement services on behalf of CRCs around the country, and I think all CRCs are currently still in a transition period. I think although TR kicked in 2015, it was such a huge change to split such a large statutory service into 21 effectively private sector organisations, and so I think there are areas that are ahead of others. I think a lot of that is caseload based. You guys are obviously the biggest one. So I think some volumes it plays a huge part in terms of managing the number of people you need to manage. But I also think that resettlement services are only as good as the services they're able to refer into. And I think this brings us back to access to housing, access to jobs. And I think we can have great intentions and we can make 100 referrals for someone into housing. But if the local authority don't deem them a priority need and there's private landlords, they can't get deposits for private rented properties, and so I think resettlement services I think vary in each area. I think some are doing better than others, but I also think provision varies in each area as well.
So are you suggesting that London may be a tougher town to run a resettlement service in?
No, well, certainly if you look at the price of rent and living in London, it's certainly more difficult, I think, to house people in London. I've got services around the country, and it's much easier for us to pay a £200 deposit for someone in Newcastle than it is a £2,000 deposit in London. So I certainly think housing is much more difficult in London, and the lack of housing, and obviously for me, that's the
yes,
most
the
important.
Baseline, isn't it? Yeah.
You can't expect anyone to leave custody without a house and be well mentally, but also get a job and succeed.
It's stability. I found at my own youth work, it was the bottom line.
Yeah,
where am I going to sleep tonight?
Yeah.
Okay, yes.
Yeah, I think I would just add, in terms of picking up that point around accommodation, so a number of service users potentially are going to be NFA on release from prison, and that will provide quite challenging situations in terms of registering them with a GP so they can start to access some of that primary care. So again, one of the things that from a London CRC perspective, we've worked with NHS England to set up a GP registration service so that service users can use the probation office as their address to enable them to be able to register with the GP and therefore start to be able to access those services. But I think it really just echoes the point of the challenges of not having a fixed abode within London and what potentially some individuals might end up not being able to access the services and support they need.
Well, I just want to carry on with the theme of reintegration. Of course, one of the needs is to integrate into the healthcare services, which is primary care, and also into the community mental health service, but also the other issues about which you picked up about housing, employment, substance misuse, drug addiction services. How difficult is it, are you finding, getting into those access services? Because I can see my background is general practice, right, and I know the problems which we get in getting patients transferred from the service to us, right, and how the capacity of general practice is then to pick them up, right. Okay, so how are you helping us, guys?
Sometimes I think it's not necessarily that the services are not there, but it's people understanding how to access them. So we deliver generic kind of resettlement services under TR across the country, but we deliver a specific mental health resettlement service from the Greenwich prisons, so Belmarsh, Thameside and ISIS. And that's a really intensive service commissioned by Oxley's NHS Trust. And that service effectively works with people who've got high-risk mental health concerns in custody for 12 weeks. We work closely, obviously, with the CRCs because they're providing the statutory resettlement services, but in order to get people linked up with GPs, with dentists, so we physically pick them up on the day of release, we take them to the doctor, we take them to the dentist, we take them to the community mental health team, we take them to substance misuse appointments, we take them usually on the day of release straight to the housing office to have quite a long argument about the fact that they're someone's responsibility to house.
So you do this on the day of a discharge,
so
rather than, say, planning for the discharge?
We work with them 12 weeks prior to discharge. So we set up as much as we can prior to discharge. Okay. If they've not got accommodation, then that's when on the day of release we take them to the housing office. But I think for me, having delivered resettlement services for a number of years, working specifically with this cohort, it's a huge eye-opener that actually this provision is only operating currently in the 3 prisons in Greenwich and 2 in Kent. And so there's a similar cohort of people in custody throughout the country who don't have this intensive kind of through the gate service and support prior to release, but also post-release. So I think if they've not got a GP, a lot of people, if they're released without that intensive support, it's where to find a GP, who do I go to? So I think it's not necessarily that the services are not there, it's getting people to from A
So
to B.
you think the services are there,
Yeah.
but they have difficulty accessing them? That's your experience?
Yeah, or understanding which services are right for them, I think.
Okay. Casey, you want to go?
Yeah, I think in terms of the service provision within the Greenwich prisons, so London CLC delivers a through-the-gate service in the other, or in London prisons, of which we commissioned St Mungo's to provide an accommodation service. So initially, on receipt into custody, they will do some tenancy support work with anyone that may be at risk of losing their tenancy as a result of coming into the custodial environment, and try and sustain that tenancy for when they get released. If, unfortunately, that's not always possible, they will do the work 12 weeks prior to release to look at the options for them to be housed. I think, sort of anecdotally, and I don't have the specific volumes of this happening, but certainly in my experience, one of the things can be that through committing an offence, some local authorities will think that they've made themselves intentionally homeless, and therefore will then find it very difficult to be able to access those housing provisions through the local authority, which then leaves you with a very sort of restricted route around sort of private renting, which can obviously comes with huge challenges when you perhaps don't have an income stream and can't get a deposit together. So the service from St Mungo's is carried on into the community, and housing options are discussed, and NFA sort of no fixed abode support is also provided as part of their ongoing support in the community. But there are some very real challenges in London, and my colleague picked those up, covering around the amount that it costs to rent in London, and actually what we're seeing is a number of service users that are getting pushed out further and further and further, which when it comes to people's mental health, they've been particularly ostracised from potentially their family support networks, and that doesn't help.
So there must be huge variation across London, because if local authorities can make their own interpretation of the law, right? So there are some boroughs who accept responsibility and some don't. Am I understanding this right?
It can vary, and what will also vary on top of that is then what the threshold is and what the pricing of the rent is within that particular borough. So, it'll be very different from borough to borough in terms of what someone's able to access, and depending on their scoring system that might be in place. So, certainly from a sort of a probation CRC perspective, it can be particularly challenging to support an offender through that process, when actually those parameters can be confusing if they differ from borough to borough.
Okay, so that's health service dealt with, housing dealt with. How about employment? These people need help with getting a job, back into life again. How are you helping those guys with employment?
I think for, absolutely, employment is a key aspect to people's reintegration into the community, and London CLC recognises that. I think it comes with huge challenges when actually we've got a large proportion of the prison population that sometimes are illiterate and don't necessarily have the skills. So there's a huge piece of work that needs to go on before that in terms of giving people the skills and experience to make them more employable. So obviously there are services within the custodial environment that can support with that, and London CLC works actively identifying employers within the community that will employ people with a criminal record so that we can improve their chances of accessing that. But there's still a long way to go.
I think from an ACRO perspective, we, for a lot of years, have delivered custody resettlement, and I think you get to a point where you are supporting people to be what we would regard as job ready, but then if everyone's hitting a wall when they come out because employers don't want to employ ex-offenders, you're almost building people up to knock them down again.
Yes.
So we're doing a lot of work now around kind of educating employers of the values of employing this population who oftentimes, if they've been in custody, have been in really intensive training programmes. They've gained a lot of qualifications. Often have got extensive CVs already. So we've developed in the last few years an employer advice line. So we've got a national resettlement advice line for anyone in custody to call, any professional working with an individual. We've now developed the employer advice line because I think that employers need to be receptive to employing people with a criminal record.
It seems like the employers need to be educated too, because there's a lot of evidence to suggest that people who are ex-offenders are quite motivated and want to prove themselves to be good employees, right?
Yeah,
but they are prejudiced against them.
We've challenged a lot of decisions that employers have made, but just simply based on a criminal record. So we've produced extensive guidance for employers around how to risk assess people with a criminal record to make sure that you're getting the right person for the job rather than just saying no because they've ticked a box. And we're doing a lot of work around the Ban the Box campaign, which effectively would take the criminal record question off application forms, and a lot of large employers have now banned the box. So I think for me it's about educating employers that actually this is a pool of people that, like you say, they've got a lot to prove, but also they really want to progress and have been in training in custody, and if they've not been in custody oftentimes have got all the skills that are required for the role. So I think you've almost got to do work at both ends. You have to make sure that employers are receptive to receiving people with a criminal record, but also make sure that people with a criminal record are in the right place to go into employment.
Andy, you're keen to come in? Yes.
Yeah, and I mean, I think that's absolutely the way to go. I mean, we when we last had a look at the employment support available to prisoners with mental health problems, very often work in prisons is training people in skills that aren't very useful in the community. So kind of make-work type activities rather than real kind of skill development linked to employment opportunities. And certainly what we found, and again talking to people that have been in prison, is that their experience of being released is effectively as big a crisis as going into prison. It's not a time when it's not a great happy time for them, it's a time of enormous anxiety. There is a very serious kind of rise in the suicide rate in the first few days after leaving prison, so there is something incredibly important about providing people with really good support at that time and literally regarding it as a crisis time. But in terms of employment support, we've recently been testing out in the West Midlands, taking a model which we know to be incredibly effective for people in community mental health services, called individual placement and support, and adapting that to people that are coming out of prisons in the West Midlands. The initial findings for that are incredibly positive. And the way individual placement and support works is, first of all, it integrates healthcare with employment support, so you don't separate them out and do them in different places. You don't have any exclusions, and one of the things we found when we looked at vocational services in prisons is very often they excluded those with the most serious mental health difficulties. So that's setting up people to fail immediately. But yeah, you work with someone, you find out what they're good at, what their skills are. So rather than making people job ready, you find out what they're already good at, and then link them up with an employer in the community and get them into a job as quickly as possible once they leave. And of course the variable times at which someone's coming out of prison can make a bit of a mess of that, and the housing issues can make a huge mess of it. But where it works, when you get someone into a job, you then offer them ongoing support for as long as they need it, them and their employer. And there is mentoring support available. We find very often that employers who take people on end up actually getting quite committed to those people and providing a mentoring role, and line managers actually say they really enjoy the fact they're mentoring someone and helping them to get their life back on track. So again, we really need to look at where the evidence is in this area and make sure we're building on an already effective approach and really testing that out at scale now.
Sorry.
Yeah, I think I'd absolutely echo the point, and it is that collaborative multi-agency approach that's going to be absolutely crucial here to making this work, and not working in silos by addressing someone's mental health here and then finding them a job, and bringing those all together. Because I think, you know, you raised the point around anxiety levels at the point of release. I think there's also those low-level anxiety and low-level depression that perhaps sometimes can be under the radar and really affect someone's motivation and therefore their potential to hold down a job full-time once being released. So I think, you know, there are some examples in London where there's some really good co-located services where you've got sort of substance misuse providers, employment services, forensic mental health practitioners all working under one roof alongside the probation services, so that when a service user attends, they can see those services in one place, and actually brings all of those together to ensure that we work in a holistic way, and so that the support is ongoing for some of those low levels depression, anxiety throughout that person's journey into employment. What we know is a lot of these individuals have not necessarily held down jobs successfully for long periods of time, and that can be quite daunting to them. And actually, it's then the next stage is about financial management and how do they manage their bills, etc., because many of them may not have experienced or had to be responsible for that, which again potentially could raise their anxieties or potentially trigger depression, etc. So I think we need to make sure that we do all of these together rather than assume we can treat them in isolation, and there's a stopping and starting point.
When you get people back into mental health services, being an ex-offender, is it held against you in some way? Or is it more difficult to get back to mental health services if you've been an ex-offender, or does it make no difference at all?
I don't think in terms of the ability to access services, I think maybe there's something about the willingness to access services, and again that fear of re-engaging with the statutory service, that if you, for example, if you've been on licence for 2 years and you complete that, the fear of then re-engaging with the statutory service, I think that's probably where there might be a barrier, but it's obviously a barrier that then people need to be supported to overcome. And again, I think that's awareness of services, and again, it's about that fear of am I going to be put into hospital, and so I think it's making sure that people are clear about what access to services means, and that kind of barrier of it's another statutory service that I perhaps want to steer clear from. I think that for me is probably the biggest barrier.
Okay, thank you. Sean, you want to say? Sorry.
So just to add to that, I think there are sometimes some misperceptions or challenges amongst mental health services around working with offenders. Yes. So I think our services find that when they are wanting to re-engage somebody with services or refer them to a new service, that if they're coming from a criminal justice agency, it would be perceived as, because the referral comes from liaison diversion and a justice route, that therefore they need to go into a forensic pathway, which is a quite higher threshold and higher tiered service. It's a specialist service, really. And if you've committed a crime, it doesn't necessarily mean you need a forensic pathway in mental health care. And there's sometimes some misperceptions and challenges around that, where services, are anxious about working with offenders and feel that they need to be in a forensic pathway. And I think that's across primary care as well. I think there are some challenges around that.
Thank you.
So a slightly broader question. In all of our investigation into mental health, very rarely do people talk about mental well-being. We're always at the health and the problem end. And Andy used the term a crisis point being released. What work is done with people as they enter the prison system or as they leave to help them maintain their good mental health? Because obviously, if you have the ability to maintain your own mental health, you're less likely to have any other thing go wrong with you, re-offending, etc., etc. Is there specific things that are done with new prisoners and leaving prisoners around maintaining their mental health?
Well, when people come into prison, they have a full health screen, a full physical health and mental health screen on reception of coming into prison, initial screen on reception, and then a full assessment within a week of being within prison. And then there's a primary care pathway, the same to what you would receive in the community. And within primary care, they work... But
doesn't all of that happen to me, that primary care pathway, if I have a mental health problem?
No, you'll be eligible for primary care services, your GP for your health and your general health. And if and then if there are mental health problems, there's a pathway depending on the severity of the mental health problem. But within our service specifications within the prison, for the prisons, we are working towards much more exactly that, a health and wellbeing model. And the last procurement we did for the Greenwich prisons that were mentioned, within that specification was a health and wellbeing model, which looked much more holistically at the care to try and address those issues around more positive mental health. And as our contracts come up to be procured again, we will integrate that health and wellbeing model into those services again to try and maintain positive mental health and look at it as whether you've got a substance misuse problem or, you know, a mental health problem, actually it's a well-being approach we're taking to enable you to look after your well-being whilst you're in prison and then on your release as well.
Will CRC be doing something similar? Because obviously you're dealing with people at the other end. Are you doing, if I was one of your clients and I hadn't flagged up mental health, would one of your support staff be able to say to me, okay, you may have not flagged up, but here's some things you can do to keep your mental health in a good place or prevent it going to a bad place? It just strikes me that that conversation is, you only talk about mental health when it's perceived of going wrong.
I suppose if you're talking about it from a point of self-disclosure, then absolutely there are skills within our frontline staff to be able to support individuals to know how to maintain their well-being. I think where the challenges come is if that isn't something that's flagged up to us by the service user, and that information can't be disclosed to us via the prison in-reach teams for confidentiality reasons. So actually we don't know what we don't know. So yes, absolutely, our staff are trained to pick up on those things, but we aren't a mental health provider, so there's only a limit to what we can do without being professionals in that area.
I think this is the point I'm making though. At a very low level, it should just be assumed we all have some mental health and we're somewhere on that scale, and shouldn't someone be talking to us about how to stay at the good end of that scale? Because if you look at these figures for suicide 28 days or less after release, we know something happens there, but nobody is saying to people, be wary that you may feel down because you can't get somewhere to live, employment's tough, you know, here's things you could be doing. If that could be done universally across the board, it certainly wouldn't do any harm.
I think certainly by the prison as well that could be done. Yeah. So I know that some prisons are better than others, but in some prisons they've got first night centres, and they certainly have first night in prison wings, so you're not thrown straight onto a chaotic wing. And I think a lot of prisons on induction, they will provide people with as much information as they can about kind of the difficulties of adjusting, and so it does depend on the prison. It's not universal, but I also think where we were talking about prison staff being better trained, because sometimes it can be a couple of days in before anyone will access. I mean, it could be up to 8 days in before they'll see the CRC. So for those kind of first nights in prison, sometimes I think the prison staff need to have a better understanding of how, because effectively they have more contact with the service users than any other agency in custody. So for me, I think some of it is around the first night in prison wing, and how we can upskill staff there to make sure that people are able to have difficult conversations if they need to, but also that people are given as much information as they can around kind of coping strategies, like you say, and it's not done universally. Some prisons are better than others. But yeah, I think it is. I know some prisons are starting to look at trauma-informed approaches and understanding that ultimately everyone who comes into custody is likely to have experienced some kind of trauma, whether it be low level as a child or whether it be recent trauma. And ultimately, I think everyone walking the streets has experienced some kind of trauma. So there's a lot of work in CRCs and in custody around how do we take a trauma-informed approach to everyone, to just understand that the individual sat in front of you is likely to have gone through, it might be a lot, it might be not very much, but to them, some kind of trauma, and how do you make sure that you integrate that into the way that you work with them? But it does vary, it's not across the board, I don't think.
Thank you. Thank you very much. Jeanette?
Yes, reoffending.
Yes, indeed.
Thank you, Chair. Right, the Mayor and and staff from his Office of Police and Crime have committed substantial funding to improving services specifically to reduce female reoffending. And it has to be said that both the former and the current Mayor, through MOPAC, have focused on this issue, and quite rightly so, because as we understand it, around 300,000 women are arrested each year in London, making up a third of all offenders sentenced at court. Of these, over a fifth go on to reoffend. So my first question to Andy Bell, if I may. Andy, from your work at the Centre for Health, are you able to say whether poor mental health support is a key driver in the reoffending rate of females in London? Have you covered this area in your work?
Not specifically looking. I mean, the evidence about the links between mental health difficulties and offending for anybody is actually quite mixed and quite limited. And very often we find that offending is there may be links to poor mental health, but it's often confounded by drug and alcohol use, issues relating to safety, and particularly for women, offending is different to men on the whole. Very often there are links to particularly not being safe, so I think, I mean, it's not something we've specifically looked at, and I don't think that the research is fantastically strong, but I think there is no question that for women in the criminal justice system, we know that imprisonment is even more disastrous than it is for men. It's now 10 years since the Colston report came out and said that we should really be working towards phasing out women's prisons and replacing them with women's centres in the community and more appropriate sanctions for offending. Sadly, we've made very little progress in terms of phasing out the women's estate, and we still imprison much the same number of women as we did 10 years ago. And I think we really need to kind of have another look at that and say, well, what is an appropriate response to offending among women, and how can we reduce the risks of reoffending? But also, how can we ensure that women who are predominantly the primary carers of children who go to prison, how can we support them in their family role? We know that presents a huge risk to their children in terms of a huge range of poor outcomes later in life. So you're setting whole families up to fail in many ways if you put women in prison. So I think this really does require a properly whole system look. Sorry, it's not entirely answering the question.
No, it's fine. No, I think because maybe what we can do to pursue that is to ask organisations like the Howard League, because I know that some work has been done on that. And in fact, one of the issues that came up was that the amount of funding spent on this area. And so in January 2017, Mayor Khan announced additional funding to help reduce female reoffending. And at that time, he said, support for female offenders in the capital has been historically underfunded, and the need for more services has become increasingly acute as a result of the closure of Her Majesty's Prison Holloway last summer. I know about that campaign because it's within my constituency. So the funding, as we understand it, included £500,000 to set up a new female offender service in partnership with London CRC. So my question now to Cathy Newman, and I'm being quite specific about my question, is will London CRC be taking a targeted approach in terms of how this extra funding will be used?
Yes, that co-commissioned approach to funded a key worker service to support women in I think it's 15 boroughs in total across London, in providing additional services beyond the statutory services provided by London CRC to female offenders. So that's an enhanced service to provide access and support to perhaps mental health services, but employment opportunities. Because what we know is that a number of women perhaps will engage better with non-authority services or non-statutory services, and need that extra support to enable them and encourage them to engage with the provision of extra support outside. And so that's what that funding was used to do. It's in its very early stages, and I'm not in a position to share any sort of evidence in terms of its successes at this stage. But London CRC recognises the importance of dealing with women, the female service users, in a slightly different way, and we use a very much a trauma-informed approach in terms of how we do that, recognising the reasons what brought them in, are likely to have brought them into the criminal justice system in the first place. As part of that, we've set up, building off the back of the Colston report and identifying the need for women's centre hubs. There are 2 hubs in London currently, and we have ambitions to create additional ones around London that are specifically female-only reporting areas with additional services co-located in the same place to enable, again, as I said earlier, that kind of enhanced opportunity to engage with multiple services, but in a therapeutic environment at the same time. And I think one of the things we need to consider is how we utilise those as alternatives to custody to try and reduce the prison population from females.
A couple of questions. Are those two centres within proximity of the 15 boroughs that you're working on? Working in?
No, not at this stage. We are in discussions to set up additional ones. So the hubs are currently in, one's in Lambeth and one's in Sutton. And the boroughs that we work in don't currently cover those in terms of the additional service. So we have they are commissioned in a slightly different way, but provide a very similar kind of service.
So you've got an approach that you're thinking is positive, and you've got extra funding, but you are not using that to bring about more women's centres.
So,
is that right?
Not completely, no. The funding from the Mayor's Office and the co-commissioned service came after the setup of these two initial hubs. So these hubs were already set up and functioning, and they're funded through a different funding stream. The key worker service that's co-commissioned with the Mayor's Office was set up based on where we identified additional need and the volumes where we felt that actually we could target more women and have an impact on a greater number of people, rather than resource and invest heavily in two boroughs and actually miss the opportunity to enhance the services across London.
Okay, so it's targeted in a way. And just staying with the women's centres, where did the research come from in order for you to get involved in that work, or are you building the evidence base from these two centres to help you with the rollout?
The initial one that was started in Lambeth, which as I understand it was one of the first ones in London, is led by the local authority, and so I'm not aware of what the basis was for that, other than probably what the need was in that particular local authority at that time, and they were quite innovative and forward-thinking in terms of creating it. But certainly the evidence that's coming out of that particular centre is what was utilised to help us to identify another centre in Sutton, and you think about what its resources were needed to be around and what additional agencies we need to help and provide a holistic service. So we are growing that, and we have ambitions to extend that. However, we are only in a position to do that within the remit of our financial envelope. So,
yeah, but I just think it's so important that we sort of continue to work on an evidence base, and that evaluation takes place, and it's based on that evaluation rather than your need to win the bid, get the money, and then just go off and get the building, because that seems to be an approach that's failed us in the past.
And I would absolutely agree with you, and that's certainly not the approach that we would take. We would look to learn from those particular centres. Our ambitions are to ensure that we have a pan-London service where the hubs are strategically placed well to enable the most amount of women to be able to access those services based on the evidence that we've learned from those.
Okay, and just, you heard me talk before, and I focused then on the black male mental health user group. I recently met International Women's Day. I invited just a whole gathering of women here, and many of them came from hostels that are run by black women, and they were running their own regarding mental health and sort of support post-prison, because the services were so desperate that they were being offered. Are you going to be focusing on that particular population, black women, young black women in this population?
I think it's something that we would need to look at. I don't have the data to hand in terms of the prevalence of that, but absolutely where there's a need and an overwhelming gap in the service provision, then that is something we would want to capture and consider when we're looking at the extension of those hubs. I mean, you know, if we look at Lambeth, what, you know, having come and worked in that borough, the population and of ethnicity of black and minority women is greater than it is in Sutton, for example. So certainly there is a provision in that particular locality, but absolutely we would need to consider and ensure that that is covered across London as we're able to try and increase those service provisions.
But is that part of your operational analysis and monitoring, that you're looking to see user profile? Because it is possible for a service to be saying it's given a service in Lambeth and not to have a percentage of black women. I've seen it before, and it wouldn't surprise me if it happened again, because it has to be positively done. So is that part of your operational model?
I think it's certainly part of our ambition. I think in terms of where
Your
we're
ambition,
at
but you don't do it at the moment. What's an ambition? What do you mean? Is it part of your modelling or is it not?
Well, it isn't currently, but I would absolutely say it's part of our ambition to do so. We're a service that's going through a significant amount of transformation, and we need to ensure that we capture those things as we build on the basics going forward.
So you're actually spending money that really you haven't got a clue whether or not that will meet the needs of, say, a significant population like black women in London, because you haven't set up your structure to monitor their use of it.
I think we're in the very early stages of the key worker service that's been commissioned with the Mayor's office, and I think the early stages we need to, there is an evaluation team that sits behind that in the Mayor's office that will help us to learn from that evaluation, to then be able to continually shape it as we go forward.
Well, I mean, through you, Chair, maybe that's something that we ought to address with MOPAC, because I'm not filled with confidence here. NACRO, can I ask you, Helen, in terms of targeting service, especially to female reoffenders, we have an opportunity here. Are you aware of this? Are you knowing what London CRC, is it? What your colleague is doing?
So we don't actually work with any female offenders in London currently, so I wasn't aware of this.
Why is that?
Funding streams, I suppose. I think previously a lot of our work was in custody, so we did work in Holloway until it closed.
Oh yes, of course.
Yeah, so we provided resettlement services in Holloway up until the day of closure, but that was on behalf of Essex CRC. I think my frustration in terms of females, particularly females in London, is that the whole point of transforming rehabilitation was that we keep people close to home, especially women who often have children visiting. And Holloway was perfect for that. If nothing else, people criticised Holloway, but actually it had a lot of positives. So certainly for London women and our Essex women now, they're in Bronzefield at Heathrow, they're in Surrey, and they're in Peterborough. So anything that we can do to support women once they're released, I think is great. I wasn't aware of it, but I'll certainly look into it. But I think my worry for female offenders is custody now. Female offenders returning to London is that they're going to be so far from home. I think that's a real concern for me, because in order to deliver what I think is effective resettlement, you need to have a good knowledge of what's available for them in their area. If you're in Peterborough, you don't know what women's centres are in Holloway, you don't know what women's centres are in Lambeth. So I think it puts, if anything, more pressure on the CRC when people are released back to London because they've not had a close-to-home resettlement service in custody. So I think it is, I think it's certainly money well spent, because it will be needed, given now that women are not in custody in London.
Okay, Chair, we don't have the time for me to go into any more detail, but I would, through you, seek to be putting some more questions on this to MOPAC. Because, my goodness, as we've heard so ably articulated by Sinead, if we can't do more about, stopping the reoffending in women, then their children are the next lot of criminals coming through the system.
Okay, Umesh was going to pick up on the Mayor and the MOPAC, and so we'll set in this. Over to you, Umesh.
Thank you, Chair. So going forward, and looking at the role of the Mayor in MOPEC, and I have a series of questions. The first question is really to all of you. What should be the key focus for the Mayor and MOPEC in ensuring quality mental health provision for offenders in London? If you could be specific and concentrate on one area each. Do you want to start off, Andy? And then...
God, there's so much. I've got a long list. I mean, I think one of the areas we really need to focus on is to understand one of the main duties of the Mayor is to reduce health inequalities.
So-called?
Is reducing health inequalities. It's a key fundamental role of the Mayor of London and promoting community safety. And I think the important thing here is actually you can do both at the same time. And really, I think the key here has to be about focusing on earlier intervention. It has to be looking at how we are supporting children, girls at risk of involvement in gangs, young men growing up in estates where their safety is constantly at risk, children growing up in families where they're not able to manage their behaviour and problems are spiralling out of control at a young age. So I think there's a fundamental role about supporting families and young people to really reduce those risks of later negative outcomes happening. We know that in a lot of areas outside London, police and crime commissioners, which are the broad equivalent, have invested their crime reduction budgets in things like parenting programmes and really early intervention and support within schools. Again, based on evidence, doing things we know have the greatest chance of having effect, doing so with an understanding of the race equality dimensions to this. And there are lots of things, doubtless, that can be picked up about supporting people who are already in the system. But for me, the big gains in terms of improving people's quality of life and reducing inequalities are working with children and families.
I think from a probation CRC perspective, we would welcome any additional support that can help in order to properly signpost people into the right treatment, and whether that's sort of the mentoring support alongside that will help to improve people's confidence to want to talk about those issues and overcome some of the challenges in relation to engagement and motivation, as well as perhaps some of the lower level interventions and support services that can improve people's sort of health and well-being on a lower level. I think the service provision exists quite well for the more acute end of the scale, but it's that lower level that we see that has an impact on people's compliance with interventions, and we really struggle to get people to address their offending behaviour when those low-level mental health issues aren't being addressed.
I would agree with the kind of low level. I think for me the issue tends to be the thresholds, and certainly where we do pre-release work in custody. I think if there was the lower level support for people who, and it is about well-being rather than mental health all of the time, and I think if there was more access to that, then everyone leaving custody would be able to access a more comprehensive service, but also people who are not in custody and are just on community orders or licences would have access to services, because I think threshold, because of the difference in thresholds, we tend to get people who slip through the net.
A lot of the work we do is about identifying people with vulnerability who come into contact with the criminal justice system and then try to respond to that crisis point in their lives. I think a lot more could be done in terms of the prevention agenda to stop them actually reaching that point where we need to make that intervention. But if they do get there, I think there's a lot of work we can do constructively to work with police forces to offer alternative routes rather than females being prosecuted and people being prosecuted generally. In terms of out-of-court disposals, how we can work increasing the use of community resolutions and conditional discharges, lower level responses which allow people to carry on with their lives in the community, but with appropriate support.
I would echo Glyn's comments, and obviously we were consulted, as many people were, on the Health and Police Crime Plan, and the particular focus on children and young people is welcome for us, and particularly keeping young people out of police custody where possible. We know that London is a bit of an outlier for the amount of young people that come into police custody. and we would hope very much want to work in partnership, which we are doing with the Metropolitan Police, around how we can support them and what our services in custody can do around the response to children and young people. So we'd welcome continuation of working with MOPAC on that. And also on the conclusion of David Lammy's report into inequalities amongst BME groups within the justice system, I would really welcome MOPAC and ourselves being able to support that and taking any pertinent recommendations forward.
And I mean, looking at the devolution agenda, what further devolved powers do you think the Mayor should be asking central government in any future negotiations? Again, I mean, this is to all of you. Any specific thoughts?
I would just say, you know, from a CRC perspective, we're watching that debate with interest, and you know, we continue to want to work closely with the Mayor's office to ensure that London is a safe place to live.
I think there's an interesting social experiment happening now with Greater Manchester. Obviously, having now quite ambitious plans around health and social care. The West Midlands recently published a very interesting report looking at how across that metropolitan area they could support mental health and well-being. That focused only on adults, but within that there was a significant focus on criminal justice. So, for example, increasing the use of community orders with mental health treatment as an alternative to custody for people with mental health problems. So I think it may or may not necessarily be about extra powers, but I think certainly looking at creative opportunities on a pan-London level to develop different responses that can only be done at that scale, I think has something to it. There's certainly something about supporting housing. I mean, it's come up time and time again in this discussion, and I'm sure it does in lots of discussions about providing proper housing with support where needed for people who've had mental health difficulties in the criminal justice system. And I think something about being able to hold agencies to account for the mental health support they offer to people who are in the criminal justice system. Because at the moment I think we are leaving it up to chance and goodwill on the whole. And you know, with 32 boroughs, 31 CCGs, that's an awful lot of organisations with very, very little oversight in terms of what support they're providing to people in the criminal justice system with mental health difficulties.
Anyone else? I mean, are there any other specific London needs that are not being met through the current commissioning system?
For me, I think it's that threshold thing again, but I don't think that's London specific. I think
Sorry, could you repeat that?
I think it's just thresholds again with high level need perhaps being met, but when we talk about just general well-being and people's awareness of their own well-being, I think that there maybe needs to be some, but I don't think that's London specific.
Well, last set of questions for Necro and Andy, but are there any other parting thoughts from anyone else? No. Well, in that case, my last question would be to you, Andy, and to Helen. What could the Mayor do through his wider policy brief to better support mental health for ex-offenders? And Andy, very specifically, your report was back in 2013 about BME men. I mean, 4 years on, is there anything specific? My colleague Janet Arnold has asked a number of questions, but is there, concentrating on that report 4 years on, is there anything specific that you think that the Mayor can be doing at this stage?
I think there's still a need actually to keep this issue visible. It is an area that is almost invisible in mental health policy nationally. There isn't the focus on race equality. There hasn't been since 2005 when Delivering Race Equality was published, which is now an awful long time ago. So I think there is certainly an incredibly important need, and London is a natural place for it to come from, for there to be that focus on both developing the evidence about what works to provide more equal support for people's mental health, but also to really hold the system to account for how it is investing in those areas. I think there's something certainly about how the Mayor can link up with community-based organisations. We hear time and time again about how organisations that people do trust and find helpful are existing on very, very short-term bits of money, living from hand to mouth, coming and going, disappearing because they haven't got the long-term support. And actually, I think engaging directly with communities and encouraging the boroughs to do the same. And again, we know that actually there's a great example, which is nothing to do with London, from Blackburn, of where they produce their JSNA not by creating lots of data, but for children's mental health, they actually went and talked to children. And they particularly sought out children from the Pakistani community, which is the main minority ethnic group in that city, to understand from their perspective what helped and hindered their mental health. And I think that's a real example of how, rather than this being a data-driven exercise, actually engaging with communities, finding out what helps and hinders them, getting communities to do research for themselves rather than having stuff done to them all the time. And again, these can't all be done by the Mayor, but I think with the coming of Thrive London, there is a real opportunity to really change the game in London on mental health across the whole piece. Working with the fact that we've now got more than half of London boroughs have a councillor who's a member champion for mental health. Many of those are acutely aware of and wanting to make a difference on race equality issues. I think there's less interest in criminal justice and mental health, but that can certainly be built up. So really creating a social movement for mental health and making sure that we don't do what sometimes happens, which is we forget people in the criminal justice system and we forget black people within that and just focus on it kind of being a white middle class thing. So sorry, that was a very long answer to a short question.
No, but you touched on some pertinent issues. Like, Helen?
Got nothing to add, I think.
Nothing there, fine.
Yeah.
Check. Yeah, finish. I mean, I'm just thinking whether formally through the Secretariat we can send the notes of this meeting to the Police and Crime Committee. Because clearly there's a lot of meat here, and mental health is a very important issue, which I think we'll be addressing at some stage, even if not formally through take evidence, through question and answer. Or
We can do that. Certainly, thank you. Thank you very much for your contributions. If you feel that there's something you wanted to say but you didn't have the opportunity, please write to us. You're still able to do so. If you come up with any ideas of what the Mayor can do specifically, please let us know, because we will be producing a report. We've been working on the mental health issues in the various groups over the last year or so, and we will be producing a report, comprehensive report for the Mayor, okay, so to affect his health inequality strategy, and also I know that he's a great champion for making mental health as a parity with physical health. So we're open to taking evidence and suggestions, so don't feel that this is the end of the story. Please feel free to write to us. But I want to formally thank you for your contributions. And can I ask the committee to note the report and discussions? Thank you. Can I also ask the committee to delegate authority to me, in consultation with the Deputy Chairman, to agree any output from the discussion at today's meeting?
Agreed.
Can we please agree our report on mental health, disabled and deaf people?
Agreed.
Thank you. Can I ask the committee to note the topics covering the 2016-17 and agree the priority topics for 2017-18?
Agreed.
Okay. Can I ask the members to delegate authority to me as Chair, in consultation with the Deputy Chair, to agree the terms of reference and scope of the proposed review of the Mayor's health inequality strategy? Any further outputs are related to the committee's investigations into mental health inequalities and sustainability and transformation plans, and the arrangement for any site visits, informal meetings or engagements, activities before the committee's next formal meeting. Thank you. The next meeting of the committee is provisionally scheduled for 27th of June 2017 at 10 a.m. in committee room 5. 27th of June. It's after 8th of June.
Okay.
we may not be a world after that.
Okay. For us. There being no urgent business, this concludes the meeting. Thank you.
GLA Chamber Sound.